हर चेहरा बेमिसाल है, कोई प्यार है, कोई बहार है, कोई रहबरी का मयार है, कोई अपनों के लिए जवान है, कोई घर की पूरी शान है, कोई शाद है, कोई आबाद है, कोई दूर है, कोई साथ है। ये चेहरे जो हैं बिखरे हुए, ये जिंदगी के राज हैं। आए पाकिस्तान में डायबिटीज से जुड़े हर चेहरे को रोशन बनाएं। फेसेस ऑफ डायबिटीज के साथ डायबिटीज की आगाही बढ़ाएं। फेसेस ऑफ डायबिटीज।
Assalamu alaikum ji. This is Dr. Abbas Raza. I'm a consultant endocrinologist in Lahore. And again, today is a very special day. I think we have a session which is lined up, one of the two important things in this time and age. One is the COVID and the cardiovascular diseases, and the other one is diabetes. And I think as we go along the COVID times, we've been hearing a lot more about COVID than ever before. But as the time progresses forward, we also have to move on and get back to our lives. But one thing that we cannot stop thinking of is that what the COVID epidemic was all about and what are the implications of the COVID. I think we now need to think more on not only the acute problems with the COVID, which happened for when people ended up in ICU, when people ended up on vent, people ended up in isolation. But we now need to look at what are the complications of this disease, which is happening now, which is the immediate post-COVID time, and also what is going to happen in years to come. Honestly, the more you read about it, the more data comes out of the information we have from the patients. The more we will realize that this was not a flu which affected the lungs. Actually, it has a much bigger impact than we thought. One of the things which are coming up in the recent publications, which I saw yesterday and today, is the neurological effect of the COVID and what is implication is going to have. And just an interesting point from for our discussion. That if you see one of the major or one of the main symptoms of COVID has been the loss of smell and loss of taste. And this is because directly involving the nerves which directly go in the brain. And they say this is probably a sign of viruses affecting the central nervous system. And interestingly enough, if you look at the Parkinsonism and dementia, loss of smell and sometimes taste is one of the symptom of these disorders in the past too. So I'm not saying this is the missing link, but again, I'm honestly thinking what are going to be the long-term complication of it. And the other very important thing which we tend to forget, and I'm seeing as an endocrinologist on our side of the world, that is the effect on the insulin resistance. I see people going really messed up as far as their blood glucose is concerned during an endemic. And not only that, the effect of the COVID on the cardiometabolic diseases itself. And again, I think we are honored and and have a very good opportunity to discuss this with someone from the University of Birmingham, Professor Wasim Hanif, who I think I have a privilege of working on different projects with him, and also have the opportunity of see how much he's committed in whatever he does. And one of the things he's been very deeply involved is the cardiovascular and cardiometabolic effect of the COVID, and he's being an advocate of looking into that. So in next 15 to 20 minutes, we're going to hear from Dr. Professor Wasim Hanif to go over the demographics of the COVID-19 experiences from the University of Birmingham, how the experience has been as far as the effect of COVID have been on the cardiovascular. The question is whom to test, whom to be vigilant for, how to mitigate the strategic or mitigate or strategize the to achieve the best optimal results, and dive deep into associated risk of patient with cardiovascular diseases and COVID at the same time. So I don't want to stay in between you both, you, the speaker, and the audience. I will hand over the mic to Dr. Professor Wasim Hanif. Thank you, Dr. Wasim.
Assalamu alaikum. Thank you very much, Dr. Abbas, for your kind words. I'm really grateful to you for your kind introduction. And I'm really thankful for Gets Pharma for this webinar and giving me the opportunity to give a perspective around COVID-19, the pandemic, and the cardiometabolic effects of it. So now, before actually I start, let me just give you a kind of a preface about what's been happening. So in the United Kingdom, as you are aware, that we started the pandemic, or what you would call the start of the peak of the pandemic in around end of March. At that time, we had some experience about what the pandemic was actually doing in China and following that in Italy. Now, in both these countries, it was a very homogeneous population, either completely Chinese, or in Italy, completely white European or white Caucasian. Now, UK was the first country in which we had a kind of a multi-ethnic population with a very high proportion of South Asians, people from Pakistan and India, along with the Afro-Caribbean communities. The second important thing was that till we caught the pandemic in the UK, the general perception was that this was a respiratory disease. This was a respiratory virus that was causing what you would call pneumonitis or viral pneumonia and leading to ARDS. Although there were some publications coming out from Wuhan suggesting that if you had diabetes or heart disease, you were at a greater risk of dying. But generally, most of the guidelines were based on it being respiratory disease. So therefore, when the first set of instructions came for the government about trying to protect people, it was thought people with COPD, people with asthma, smokers would do really badly with this disease. And it was thought that the risk of diabetes was more because of the generalized increase of poor glycemic control. But what we have actually seen after UK and then the United States in the new publications, some of which Dr. Abbas referred to you, is that this is, so in terms of morbidity and mortality, although it's a respiratory disease, it's a cardiometabolic disease. So in the next 15 to 20 minutes, I'll just share with you some of the evidence pointing towards it and what we can do about that. So as we know, the numbers are increasing. I don't have to say in the UK, we had the second, now we have got the third because Brazil has just overtaken us. But when it comes to diabetes, it was found that there was an increased risk of dying, but there was no evidence to show that you actually have an increased risk of infections. So this was the background. We all know about COVID-19 and what it is, so I'm not going to really go it, whether it is transmitted by respiratory route or droplet infections, and there have been some suggestions that it might be aerosol borne. So there's a poll question I have got here before I start. Do you think there is a relationship between the cardiometabolic disease and morbidity and mortality associated with COVID?
Dr. Wasim, I have launched the poll. So as soon as I think I'll give them 2 minutes and I'll share the results with everyone on the screen. Dr. Wasim, I'm going ahead with ending the poll and I'll share the results with you. Dr. Wasim, are you able to see the results?
Yes. So nearly, I think 86% of the people think, yes, there is a relationship.
Yes. I'll stop sharing the results.
Okay, fine.
That's
So thank you very much. So as you think, most of you have got a fair idea that, yes, there is a relationship and this is what we are actually seeing. Now let us try and understand as to what is the timelines, or what is the actually pathophysiology of things that happen in terms, and this we are looking specifically in terms of cardiometabolic risk or cardiometabolic effects of COVID. So this was a recent publication which actually looks at a number of things. So first of all, it looks at viral shedding, and most of you are aware that it starts with a viral exposure 0 days, and about 7 days you've got symptoms onset. If things get bad from a respiratory point of view, ventilation is generally required at day 14. In those who recover, the symptom resolution happens by day 21, and in the ones who deteriorate, organ failure or death happens around day 28. Now, in terms of the cardiometabolic effects, if we look at one of the very important markers that we're seeing in patients who don't do well in terms of mortality, and also in terms of the patients who develop the cardiometabolic effect, is troponin, the high sensitive troponin. The high sensitive troponin usually tends to start rising at about day 14. This is also the time when the patients actually present to the hospital, the ones who are seriously or critically ill. I'm not talking about mild to moderate cases. In these patients, if you measure the troponin levels are much higher than in the people who actually recover. And this, if it continues to go by day 21, you start seeing a rise in proBNP, suggesting the risk of heart failure, and then you start getting the vasculitis and coagulopathy. So what it actually means. So this cardiometabolic effect that you're seeing in COVID is not related either to the virus, it is not related to the infection, it is not related to the secondary pneumonitis that patients develop. It is more related to the cytokine surge that happens with an increase in the interleukins and activated macrophages and CD4 and T cells. So it is the cytokine storm which is perhaps causing a cardiometabolic effect. Now, one of the questions that is asked and is asked by a number of people as to who are the patients who should actually be tested for COVID, and who are the ones who actually develop worse symptoms, or what we call the critical or the symptomatic patients. Now, this is a very interesting study that came in from the Lombardy region in Italy. And in this study, what they did was they went and measured the antibodies of the patients who were actually infected with COVID or were COVID positive. So they actually did a retrospective study in a wide population group to see what were the symptoms of the patients and who were actually antibody positive. And then they matched in to see the symptomatic patients and the critical patients. So what you see in younger people, they are less likely to be symptomatic while carrying the infections. So this is where the spread actually happens. The critically ill patients, the single most important factor is the age. So once you cross the age of 80, then nearly 20% of the patients are critical, and these are the patients who unfortunately generally die. And as the age comes down, the critical patients is increased. So what it really means, it means that the younger patients are less likely to be symptomatic, but these are the ones who carry the virus. The other important point from this study that actually shows is, even in the younger people, they may not, some of them may develop critical disease. So it is not saying that all young people are actually safe and they can just go about doing their business, because some of them can get very seriously ill. So when we come to this one, this is something that we did as a part of the Salvation Health Foundation. This was a meta-analysis we ran to basically look at what are the risk factors that contribute to this increased risk. So as I mentioned, age is probably the most important one. The second is obesity. The other factors are, in UK, what we call structural discrimination. So if you're from a poor, deprived background, the risk of getting this virus is higher. It is the social behavior, how you behave, because in some of the Asian communities, we have got intergenerational living, which can have an effect. And then there are things like environmental pollution, vitamin D, genetics, and there is a genome study going on from Edinburgh suggesting that there could be an increased genetic risk in certain people. Comorbidities, we are going to discuss it. Ethnicity. Now, what we are seeing both in the UK and US is what we call the BAME communities, that is Black, Asian, minority ethnic groups. These communities seem to have a higher risk. Certain occupations, which are what we call the key workers or customer facing, they have got increased risk. And of course, there is the whole issue of gender, males having it more common than females. So this just gives you an idea about what are the risk factors that are actually predicting the risk. And this is actually a meta-analysis of all the studies that have been done so far. And what it shows is, in terms of the underlying health condition, diabetes carries a significant risk. In some studies, as much as doubling your risk of mortality from COVID. Blood pressure, again, is an important risk factor. It's not fully recognized, but is a risk factor. Underlying cardiovascular disease is again a risk factor. COPD, although it was supposed to be a risk factor, as you could see in the forest plot, there is a risk, but the risk is not as high as, say, in diabetes, hypertension, and cardiovascular disease. And this is very interesting. Now, so what are the effects of COVID or in people with type 1 and type 2 diabetes? Now, one of the largest studies of this kind was actually done in the UK. So this study has got nearly 6 million people, and with a good mix of the UK population, with nearly 263,000 having type 1 diabetes and nearly over 2.8 million people having type 2 diabetes. And this is what the study shows. So this study shows that your risk of what we call unadjusted in-hospital COVID-19 mortality per 100,000 patients is much higher for patients with type 1 diabetes than the general population, and then people with type 2 diabetes also have got an increased risk. But again, in this risk, the one factor that actually drives your risk of dying if you've got diabetes is age. So as you get older, you can see your risk of dying, shown in the red line, increases quite substantially. So if you look at the risk of dying both in people with type 1 and type 2 diabetes, once you cross the risk age of 80 years, your risk of dying is nearly eightfold increased. But in the younger cohorts, the risk is much lower or nearly as same as the general population. Again, men have got twice the risk of dying when compared to females. And if you look at the ethnicity, blacks, or what we call Afro-Caribbeans in the UK, have the risk of dying of nearly double. Among the Asians, it is increased by about 30%. But if we look at the total population, what is very interesting to know is that 1/3 of COVID deaths in hospitals were in people with diabetes. And this is quite important to remember. Now, what is our experience of managing these patients? Now, this is something which is very important. What is very important to know that different areas in any country will have a peak at different points of times, and then it is going to go down. As you can see in the UK, the first peak was in London, and then now most of the cases are coming down. And as I was mentioning, 2 weeks ago, we discharged our last COVID patients from University Hospital Birmingham. So this is what we had, or what our experience was. We nearly had, at the end of some of my slides are slightly older because the numbers change. But on the whole, we treated nearly 3,000 patients or 3,500 patients with COVID. At the peak of the pandemic, we had nearly 500 patients who were in ITU. And unfortunately, we had about 810 deaths, which means about a third of our patients who were admitted to the hospital died. The ones who were admitted to the ITU settings, nearly 60% of them actually passed away. So it's a grim reminder of what we saw. Now we come to the poll question number 2. Which of the following comorbidities could be playing the most significant role in COVID-19 morbidity and mortality? I hand it over to you, Dr. Ali.
Okay. Yes, I'm launching the poll, sir. We'll give everyone approximately 1 minute to answer the polls, and then we're going to display the results. So we have the results from majority of our participants, and I'll be ending the poll now and sharing the results with you all. Are you able to see the results, Dr. Wasim?
Yeah. So thank you very much. Yes, I can see all of the above actually comes at the top with nearly 60%, while others are important as well.
Yes.
Okay. Yes, can I go back?
Yes, you may, sir.
Okay. So this is a publication which recently had, and I just want to highlight a couple of important things. When it came to our South Asian ethnicity in Birmingham, which is mostly of Pakistani heritage, what we found was that the age of presentation of COVID was about a decade earlier when compared to the white population. They had more comorbidities, and the prevalence of diabetes was nearly 48% in this population compared to 28% in the white population. So just giving an idea that the underlying burden of disease, which we see in a British Pakistani population, was different to the white population. Now, we've been talking about the cardiometabolic effects of COVID. How do these effects come into place? And this is a very interesting publication which actually goes into the possible mechanisms that could be impacting. I'm not going to go into detail, but what is very important to understand is you could be having what we call chronic conditions, which could be contributing right from low socioeconomic status to genetics to visceral obesity, type 2 diabetes, hypertension, and these are, and on the other hand, you've got disease or underlying health states like HIV, TB, hepatitis, and then you've got the acute COVID infection, cytokine surge, and the relationship between this. And when we come to the specific effects of SARS-CoV-2 infection in terms of diabetes, it is supposed to be mediated through two means. One is through insulin resistance, and the other one is through beta cells. So in terms of the insulin resistance, what we are saying is that the insulin resistance is increased, and therefore some of the insulin requirements of these patients is very, very high. But at the same time, we're also saying somehow the beta cell functions either stop functioning, or there is a momentary loss of function or destruction of the beta cells, because some of these patients at their first presentations, those with type 2 diabetes or undiagnosed diabetes, are presenting with diabetic ketoacidosis. So these are the two factors that contribute in causing hyperglycemia, then causing microthrombi that contribute to kidney damage and other things. Now, one of the other interesting things that we saw, and this has been shown in other publications as well, that your risk of mortality is highest in what we call undiagnosed diabetes or newly diagnosed diabetes. So you could see the risk of dying is highest if you had previously undiagnosed diabetes, suggesting a number of things, either an effect of COVID on insulin resistance or beta cell, or it could be poor glycemic control here that is contributing it. People with known diabetes tend to do worse than people with normal glucose, but much better than those with new diagnosis of diabetes. Now, these are some of the other publications where we've been trying to look in terms of ethnicity, in terms of the COVID and its effect. And what we found is that there is a disproportionate effect in the Black and Asian communities in the UK and US when compared to the white community. And this was some of the one of the editorials we wrote in the BMJ, trying to find out what are the factors that are contributing to the risk, whether it is just social deprivation or underlying disease, or are there any possible genetic mechanisms, either low vitamin D levels or some kind of polymorphism of the ACE gene. Now, one of the things that was considered to be quite traumatic in the UK and across the globe is the deaths which we are seeing in the frontline healthcare staff, in doctors and nurses with COVID. Now, this is one of the analyses we actually did, and our question was very simple: where doctors and the death of every doctor is very unfortunate, but we need to understand that most of the doctors and nurses actually come from the community. So what we wanted to find out was whether the cumulative mortality of the doctors and nurses was worse than compared to the rest of the community. And what we actually found was that the cumulative mortality of doctors and nurses is less, which means the risk of dying if you're a healthcare professional is less when you compare to the community. There could be a number of reasons. Doctors have got, are younger and other factors, but this is something important to reassure the frontline healthcare staff for putting their lives at risk when managing these patients. Now, in the last section, in the next 2-3 slides, I'm going to share with you some of the mitigation strategies of what we need to do. So some of the things that we were saying in terms of COVID-19 and diabetes, and this we call from the lessons from London, we're taking more atypical ketosis even in type 2 diabetes. So this is both DKA as well as euglycemic ketoacidosis. There was, because of the fluid replacement, the management of DKA was becoming challenging, especially with ARDS. In small subset of patients who were ventilated, they were requiring high doses of insulin, occasionally 20 units per hour. And if we were actually proning the patients, that actually interrupted their feeds and increases the risk of hypoglycemia. So the important questions that we needed to ask, and these are some of the important stuff, and I'm going to just go through some of the practical tips. So one of the important practical tips is to stress to the patients that the importance of glycemic control. Good glycemic control in people with diabetes mitigates your risk substantially of developing both developing COVID and, most importantly, mortality from the COVID. So good glycemic control is very important. Now, one of the concerns that were raised was around the SGLT2 inhibitors, especially with the risk of diabetic ketoacidosis. We have done our own analysis, which have shown that the risk of SGLT2 inhibitors in a community setting is no different to Dpp4 inhibitors in developing DKA in patients with COVID in the community. But once the patient is admitted to the hospital, the general advice is to stop the SGLT2 inhibitors, or if they develop COVID symptoms or become COVID positive. There was some concern around the RAS blockers, but now the evidence shows that RAS blockers should be continued unless the patient develops acute kidney injury or renal failure. The same with statins. It was shown that continuing the statins can actually be protective. Also, we know that obesity is a risk factor, so trying to be diet regularly and lose weight may have a positive effect. These are some of the ABCD UK guidelines for COVID patients with diabetes. I'm happy to share all these slides later on. Now, this is just a bit more detail. So the advice is that all patients who are admitted to the hospital should have their blood glucose levels, irrespective of whether they have got diabetes or don't have diabetes. Ketones should be checked in all patients with known diabetes. SGLT2 therapy should be stopped. Metformin should be stopped, especially if the patient has got acute kidney injury. If the patient is on background insulin, any of these, they should never be stopped. If the patient has got TK and HHS, they should be treated as per the protocol, but you have to be mindful not to give excess fluid because of the risk of ARDS and fluid overload. And also examine the feet of all patients. What we need to remember, as I mentioned earlier, nearly a third of our patients admitted to the hospital had diabetes as a primary diagnosis. In terms of treating them, the aim was to maintain the blood sugar at 6 and 15, which is 6 is divided by about 18, so it's between 90 and around 200. And we were also seeing a lot of what we call atypical diabetes. So this was high insulin resistance, euglycemic decay, occurring in all settings. And we were also seeing patients who were on SGLT2 therapy. And we were considering stopping some of these patients in patients who were unwell. Following this, as you are all aware, the recovery trial came, which was great. We were part of the recovery trial, which showed that using dexamethasone actually reduces your risk of dying from COVID by a third, which is positive, which was one of the big major positive trials. But the issue with this was that it actually created more problems with regards to diabetes, because once we start giving 6 to 8 milligrams of dexamethasone, it upsets the blood sugars in everyone, and especially those with diabetes. So as a part of the recovery trial in patients with diabetes, it is suggested that BMs should be measured, and if they are elevated, we have got what is known as steroid protocol. We start glycoside initially 40 milligrams at 8 a.m. and then add in extra doses and titrate at 12 p.m., which is in the afternoon. Because with the steroids, the blood glucose levels tend to rise during the day and then settle in the evening, so there is risk of hypoglycemia. If the blood sugars are not controlled by glycoside alone, then medium-acting insulins like Humulin, Insultar, and Levemir are given at 8 a.m. and the dose is titrated accordingly. And this is a much more detailed protocol of what I have mentioned about how to manage patients on dexamethasone with COVID and diabetes. And I'm happy to share this with you. And finally, the most important thing is around prevention. And there are lots of information available on South Asian Health Foundation. We came up with the recommendations about how to prevent and decrease the risk of COVID. And this gives things right from social distancing, about how to visit mosques, how to offer prayers, and things like that. And I will encourage you to go to the site saf.org.uk and download this document freely.
Thank you very much, Dr. Hanif. And I honestly think you're such an asset and such a big support for any CME. Your presentation has generated so many interesting questions. But in the interest of the time, unfortunately, I'll have to move on and maybe ask you a few questions at the end of the session. Because our next topic and the speaker is as exciting as the first one. And again, the topic that we have to discuss today is more of a multifactorial risk and management of diabetes. I think as we progress towards to post-COVID era, we need to realize that we have to go back to treating what we used to treat beforehand as well, and that is the treatment of diabetes. During COVID, how to treat diabetes, and after COVID, how to treat diabetes is one of the very interesting and emerging topics. But we have none other than a great colleague, wonderful friend, brother-like figure for me, and a wonderful, wonderful personality, Dr. Hamid Farooqi, who's coming to us from Harvard Medical School in Dubai. And again, he is also the head of Diabetes Center in Dubai as well. He's one of the most highly ranked Pakistanis in the UAE region. And I'm honored to introduce him for a talk which goes over the multifactorial risk and management of diabetes. And he's going to discuss the highlights of diabetic management over a period of time, dysglycemia and cardiovascular disease, which is the major topic in these days. And I think he's going to he will address some of the issues addressed in TCOS trial and its implication over general people with diabetes. And obviously, at the end, he will go over some of the efficacy and safety of sitagliptin combination with extended release formulation with metformin and other medication. So again, without further ado, I would like to introduce welcome Dr. Hamid Farooqi, and please ask him to go ahead with his talk. Thank you, Hamid.
Assalamu alaikum, everyone. I hope you can hear me.
If you can speak a little louder, that would be great because your voice is echoing.
Okay. Is it better now?
Yes.
Okay. So good afternoon, everyone. Assalamu alaikum. It is indeed a pleasure to be with all of you this Saturday afternoon. And I thank you for taking your time to be with us and also for Gets to have arranged this. Following up on Wasim's talk is, those are huge shoes to fill. But I think, just like you, I have learned a lot from that talk. And we will continue with that in a little bit and then move on to our main topic. These are my disclosures. So in terms of what we have been hearing, COVID-19 crisis is affecting us all globally. And that is true for where I am right now, which is the UAE. And just to share one bit of data, I know you have seen a lot of data till now, but just one more bit is that when we look at the hospitalized patients in the UAE with COVID-19, what we do find is that 40% of them have diabetes. Now, if you compare it to our prevalence, that is more than double in terms of what we should expect. And therefore, what we are in fact looking at, people with COVID-19, they have the number that they are showing up, twice of them are diabetics than what we expect them to be. Now, one of the things that probably you all have encountered since January is that there is a deluge of articles that are coming in with regards to various aspects of COVID-19, from various, not only parts of medicine, the field of medicine, experts in the field of medicine, but everybody seems to have an opinion, just like cricket or politics. So the number of the publications has gone through the roof, and unfortunately, a lot of them have not gone through the effective peer review process, and therefore we do not know how much of it we should believe. So having said that, there are obviously certain hypotheses that we are working on. And in terms of our topic for today, which are the Dpp4 inhibitors, what we do know that the COVID-19 virus does go through the Dpp4 receptors. What we also know that the receptors are quite evenly distributed throughout the respiratory tract and may help the virus gain an access to the respiratory system. And in this basic figure, what you can see is that when it is stimulated through the virus, it then increases the stromal-derived factor 1 or SDF1, increasing the effect on mast cells and leading to the pro-inflammatory cytokine release that Dr. Wasim has been talking about, which is the cytokine storm. So that is hypothesized to be one of the mechanisms by which that storm is unleashed. And if we are using Dpp4 inhibitors, we may be able to stop that from happening, as you can see in this figure from the broken down lines. So it may offer a simple way to reduce the virus entry, and more work is in progress as we speak to see if that really pans out in the real world. So I'm going to hand to Dr. Ali for our first poll question, that with 1% decrease in A1C level, what is the percentage of decrease in the risk of microvascular complication? What is your thought? 10%, 28%, 37%, or 55%?
Sir, I'm launching the poll. We have 30 seconds left, and after that, we'll be ending the poll. Dr. Hamid, I'm ending the poll, and I'll be sharing the results with you.
Okay.
Are you able to see? Yes.
Yeah. So basically, it's kind of an even spread, around 30% for the first three and 8% for the last one, which is 55%. So basically, this data is derived from the UK PDS, and that number is 37%. So what we do see is that in that particular study, a decrease in 1% led to a 37% decrease in the risk of microvascular complication. The others, in terms of any diabetes-related endpoint, decrease in risk of MI or stroke, are there for you to see. Why am I stressing on this? Is that we always need to remember that diabetes is not a one-way street. If we are able to get the patients with high blood glucose average down, we will see beneficial results. Now, just a quick glance as to the natural course of diabetes. You already know all of this very well, but you may remember that the first thing to go up is the insulin resistance. The beta cells try to match that with increased insulin production, but at some point, beta cell failure occurs. And at that point, what we do see is that the glucose levels in the body start to go up. Postprandial goes up higher than the fasting glucose, and this is where the diagnosis of diabetes is seen. But the key point here to keep in mind is the fact that the process did not start at the point that we diagnosed this person with diabetes, which is at year 0. The process started long before. And what we also know now, that along with that process, the complications have also started much earlier than the point we make the diagnosis of diabetes. If you see, the microvascular complications may start as much as 5 years prior to diagnosis, and the macrovascular complications may be 10 years prior to diagnosis. Now, the thing is that when we then look at how the complications of diabetes start to increase, it is quite evident from here that as the A1C continues to go up, we can see that the complications are going up. So the earliest one that we were able to look at have to do with retinopathy, because that is very easily quantifiable by doing the retinal imaging. And that's where you see that after 7% to 8%, the blue line starts to shoot up, and by 12%, you can see the relative risk is nearly 20%. So that again brings to the point that why do we use the 6.5 or 7 or whatever numbers we choose for the diagnosis of diabetes is based on this objective data as to the complications of diabetes. After all, why are we treating diabetes? We are treating it because we want to take care of the complications of diabetes, both microvascular as well as macrovascular. So if we do this in reverse, what we saw in the poll question was that these microvascular complications head in the opposite direction, or the chances get low. However, despite doing all of that in the realm of microvascular complications, the macrovascular complication or the CV death still remains high despite our best efforts. And it is thought to be nearly 1.5 times higher in terms of diabetic population as compared to the general population. So the whole idea is that when we are treating diabetes, we are looking at these macrovascular complications, and what we do know is that for us to be effective in managing diabetes, we need to bring these macrovascular complications down. Now, when we were focused just on the fact that we want to bring the A1C down, that did work for microvascular complications and to a certain extent in the macrovascular complications, but we came across agents that did bring the A1C down, but increased the cardiovascular mortality. And you are very familiar with the data that we had with Rosie and other agents. So now it was decided that it is not enough for a drug to show that it is decreasing the hemoglobin A1C, thereby showing us its efficacy in bringing the blood glucose levels down. But we also need to know what is the impact of that drug as far as the cardiovascular outcomes are concerned. So now, each and every agent that is being made available for us to use, we see that they need to have long-term cardiovascular outcome trials. Now, when you run a trial, what are you looking for? What are you looking for is an endpoint. What is the change on item X? So what are those endpoints? These are what have been dubbed together as major adverse cardiovascular events, or MACE. So a 3-point MACE has 3 components: cardiovascular death, non-fatal MI, if the person had an MI but did not pass away because of that, or a non-fatal stroke. 4-point MACE is just adding on hospitalization for unstable angina on top of the 3-point MACE. And then in 5-point MACE on the 4, you add heart failure to it. So when you are evaluating the results of any cardiovascular outcome trial, instead of going through all these in detail, it is simply to go and talk about a 3-point, 4-point, or 5-point MACE. Now, as I said, every drug that is going to come has to go through those trials. And in terms of the Dpp4 inhibitors, the one that we are talking about today is the TCOS trial. Going back to the standards of medical care, we know that there is one major change that has happened in the standards, which is because of the rapid accumulation of data, we cannot wait for a whole year for these standards to change. Therefore, the standards of care for the ADA is now a living document. So any change that is incorporated into the standard prior to the yearly review and are now being done as we go along. So you can always click on the link here and get what is the most new, latest recommendation that ADA has. The 3 key points which we need to remember on which these standards are based. Number 1, you have heard it so many times that we have to individualize patient care. One size did not fit everybody in terms of choosing the goal. Number 2, personalized therapy regime. Now, how is it different from individualizing care? Individualizing care is that you determine that, okay, for these particular reasons, I need this person to be at a hemoglobin A1C of, let's say, 7. How are you going to achieve that is the personalized therapy. Which of the choices of medications that you have available are you going to put together to reach to that goal? And the third thing is involving the patient. If the patient does not believe in the plan that you have put forward, it is very difficult for them to stick to it over the long term, which is the cardinal requirement in the management of any chronic disease. So this is a very busy slide. I'm just going to go ahead and make it simple as to the decision cycle. You start off by assessing the key patient characteristics. As we just discussed, it could be age, it could be gender, all those different things. And then you consider what factors are there that would impact on the choice of your treatment, which is the personalization. Shared decision-making is that involvement of the patient. You agree, you implement, You just do not let the patient go for months at a time. You need to have some sort of mechanism to see how this treatment plan is working. And then when the patient comes back to you, you review, you reassess, and then you decide whether you want to make a change or the plan is working well for you. So the first line, glucose lowering medication based on our extensive experience for decades, remains metformin. And this is based, as I said, on the efficacy, safety, tolerability, and the clinical experience that we have. And we do know from UKPDS that it does help bring us the blood glucose levels down with less hypoglycemia and less weight gain. So now, when we are talking about the management, once we are done with the metformin, there are 4 key areas that would help us determine when we consider these in terms of what our next step should be. Out of those, the ones in black that we have right now are compelling need to minimize hypoglycemia and not weight gain, in fact, if weight loss being possible. These 2, we have always done that. But the first one, that is now based on the extensive data that we have been getting from the cardiovascular outcome trials. And therefore, we need to choose an agent that would help us in terms of these macrovascular events. And also, we have to keep cost in mind. So as you can see from here, the first line therapy on top remains metformin. And then you go ahead, and since the 4 factors we talked about, our major need is to minimize hypoglycemia, because that's what the patient is there for us. And therefore, if we look at it, the prime choice, or one of the 4 choices for you to make, is a Dpp4 inhibitor. What does the Dpp4 inhibitor do, and how does it help us? That, as you may recall very quickly, incretins are hormones that are in the gut. So whenever there is ingestion of food, these gut-related hormones called incretins, which are GLP-1 and GIP, glucagon-like peptide 1 and GI inhibitory peptide, they both are released from the gut. And what do? They go to the beta cells in the pancreas and help increase the glucose uptake by muscles and decrease the glucose production by the liver by decreasing the glucagon. So the main effect is on glucagon, decreasing the glucagon, which results in both of these 2 factors and ultimately a decreased blood glucose level. These incretins are broken down by the Dpp4 enzyme, as you can see, from active into inactive particles. We do know that if we look at the GLP levels in patients with type 2 diabetes after a meal, in a person who is not a diabetic, the top line is in blue, which you see where the GLP levels are after the meal. In impaired glucose tolerance, it starts to come down, and in type 2 diabetes, these levels are much lower than normal. So what we are trying to do with this Dpp4 enzyme inhibitor is to stop that from happening and keeping the active GLP-1 and GIP in the circulation for a longer period of time. So these are the major trials that we talked about. This is the color coding for Dpp4 inhibitors, and we are going to talk about the TCOS trial for the remaining few minutes. So this basically is a trial evaluating the cardiovascular outcomes with sitagliptin, and the need for that trial, I explained to you earlier, is to show that use of sitagliptin is not going to increase the cardiovascular risk, or it does not have a negative role to play. So this is the second poll question, and it has to do with the MACE points that I had talked about earlier. So I'm giving you a hint, and I'll hand over to Dr. Ali for the second question.
I am actually displaying the second poll here now. Dr. Hamed, are you able to see the poll?
Yes, sir.
So we're going to give everyone 1 minute to answer, and as soon as 1 minute passes, we're going to stop the poll and display the results. I'm sharing the results.
Okay. So more than half the people think that this is the most important thing, which is cardiovascular death. non-fatal MI, non-fatal stroke, and hospitalization for unstable angina. So just to go over these really quick, I would agree that cardiovascular death basically is, something that is obviously irreversible, and that should that requires our utmost attention for sure, because with a non-fatal MI or a non-fatal stroke, there is a lot that is now available in terms of the revascularization and what have you. So for the TCOS trial, as I said, the primary objective was to demonstrate the risk of cardiovascular events in patients who are treated with sitagliptin in addition to the usual care, which is metformin, was non-inferior to that in patients treated without sitagliptin in addition to the usual care. So what are we looking at here is sitagliptin harmful? Is sitagliptin non-inferior, which is it is not adding on to the risk burden? So what is the primary composite outcome? We have gone through those major MACE, so it's a 4-point MACE: cardiovascular related death, non-fatal MI, non-fatal stroke, and hospitalization for unstable angina. This was adjudicated by a clinical endpoints committee, which were blinded to the therapy allocation. What were the secondary outcomes? How did the A1C do over time? Was there a change in the renal function? If they were not on insulin, how long did it take for them to go on to insulin and or another oral agent, and the medical resource utilization? Inclusion criteria, as expected: type 2 diabetes. They had established cardiovascular disease. So what we are looking for is not a general population that we don't know if they have a risk or not. They already had established cardiovascular disease. And what we are looking at is the next event to happen. A1C between 6.5 and 8. And they were on a stable dose of 1 to 2 hypoglycemic agents or insulin. Exclusion criteria, obviously, if they were on a Dpp4 inhibitor or a GLP-1 receptor agonist, or a TZD in the last 3 months, they were having severe hypoglycemia, or there was renal insufficiency. It was a randomized parallel placebo-controlled double-blind trial. There were roughly 14,500 to 15,000 people, equally split between sitagliptin and placebo. 3-year trial, age rough 65, mean, with nearly 1/3 females, and all of them were diabetics. So in terms of our results, what we did see was that there was 11.4% cardiovascular death, MI, or stroke or hospitalization in the sitagliptin group versus 11.6 in the placebo group, showing that there was indeed not an increase in the sitagliptin group. There was slight decrease in the A1C, but remember, here our goal was not to get their A1C at a certain point. Here it was to look at the cardiovascular outcomes. And if you look at people who required additional agents to bring their blood glucose levels down, nearly 1,600 for sitagliptin and more than 2,000 for placebo. So people who were on placebo needed another agent much more than those who were on sitagliptin. In terms of insulin, 542 required insulin, whereas 744 for placebo. Hospitalization of heart failure, nearly the same, and also nearly the same if they had previous heart failure. So in summary, it was a cardiovascular safety study, and it did demonstrate the non-inferiority, which was our goal, and this is how that study was set up. And the small difference on A1C, as I had mentioned before, was that we wanted equipoise, that we wanted the glucose control to be the same in both groups, not to show that this one was bringing A1C down further as compared to the placebo. And as you saw, that initiation of insulin therapy was less in sitagliptin as compared to the placebo group, showing that indirectly they were able to continue producing insulin. So, in summary, what we can say is that if you look at major core or defects of type 2 diabetes, those are beta cell dysfunction, insulin resistance, and the liver output of glucose. That is not to take away the other factors that play a role in the pathophysiology, like For example, decreased glucose output through the renal mechanism. But these are the three core defects that we see in type 2 diabetes. And then when we look at the agents available, metformin helps us with the insulin resistance. Metformin helps us with the hepatic glucose output, whereas sitagliptin, again, helps us with improved beta cell function and increased insulin synthesis and release, as well as decreased hepatic glucose output by suppression of glucagon. So in essence, these two agents work synergistically to give us the results that we need in a complementary manner. So with that, I will conclude. This is my team here at the Dubai Diabetes Center that helps me do what I do on a regular basis. So I appreciate your time and I appreciate your attention. Thank you very much.
Thanks a lot, Dr. Hamid. I'll be requesting Dr. Wasim Hanif now to conclude the session. I have a few questions. Actually, the participants have asked a few questions as well. I would request him to answer those questions as well and give the concluding remarks.
Sorry. Yes, I'm unmuted. So where are the questions?
So, Dr. Wasim, there are few attendees who have raised their hands. I'll actually allow them to talk, and
sure. That will be
they
better.
they can ask questions. So
Okay.
The first up is Dr. Harish Kumar. So Harish Kumar, I'm allowing you to talk. Harish Kumar, Dr. Harish, can you unmute yourself? So Dr. Harish,
if the question is there, you can read it off, Ali.
Okay, I'll read the questions. So the first question was, if you people could answer, is what is the role of tocilizumab in the treatment of COVID-19, even it's not yet approved for COVID-19? So if you have any comments.
Sure. As you could see, I think this was mentioned by Dr. Abbas as well. We have got a lot of treatments that have been trialed for the COVID-19. Now, in terms of the actual evidence, so this I'm talking about randomized controlled trials which have shown to be effective in COVID situation. Only 2 drugs have been effective so far. One is dexamethasone in the recovery trial, and the other one is remdesivir. There are some other data coming from Russia and other suggesting things. So tocilizumab has been suggested, but currently it doesn't have any licenses or strong evidence. This is generally in retrospective studies because it's a kind of modulator. That's the reason why it is supposed to work. But again, as I said to you, there is currently no evidence.
Okay. So the next question.
Ali, just to add on to it, I think it is based on a recent study that came out in Lancet. And there, as Wasim just said, that it may have a beneficial effect in preventing people from moving on to ventilators. But again, as I said earlier, there is so much data coming in that unless it is proven in a peer-reviewed manner, we really can't commit and say, oh, this is a proper treatment.
Okay, so the next question related to our topic here is from Dr. Mehreen Malik. It's a very general question. I think it's a little off from our topic. So she is asking that should Humulin R on sliding scale be a good option, or we can start 70-30 for first time?
On sliding scale?
Yes.
So when you're giving IV insulin, I don't think so you can give mixed insulins IV. It is usually short-acting insulins you tend to give intravenously. So whether it's Humulin S or any short-acting insulin is used intravenously, but we don't use mixed insulin. What do you think, Hamid? Is that?
Yeah, so if you are using it primarily for a sliding scale purpose, then obviously it has to be a short-acting insulin, because 70-30, having 2 components in it, would not be the right choice to use in a sliding scale sort of a situation.
So these were the questions that we had from our participants. I think we don't have any other further questions. So I think it's time for, I think one participant has raised his hand. I'll actually allow him to talk and then we'll move towards concluding the session. I think we don't have any other questions. Dr. Wasim, can you please give your concluding remarks and let's end the session.
Okay. Thank you very much. I would really like to thank Gex Pharma for this opportunity, and it was, and I would probably want to thank my colleague and very, very good friend Hamid for a very good presentation around the gliptins. What I have felt, and this is very important, because normally we in diabetes try and see that whether one drug is better than the other and all kinds of stuff. But I've always felt that all classes of drugs in diabetes have got a role. Gliptins are emerging as quite an important class in certain group of patients, and especially during the COVID crisis, where we had a lot of concerns around decay and other things. A lot of patients have been using gliptins, so I think it was very good of you to bring back the focus back on the gliptins with an excellent presentation, and I really enjoyed it. And I want to thank everyone, and especially the participants who on a Saturday afternoon have given their time, and I hope it has been useful to you. Thank you.
Dr. Hamid, do you have any comments, sir?
No, I think I enjoyed it tremendously, and once again, you know, the bit of information about COVID-19 and how they are managing it in the UK was really, really beneficial, and I hope all the participants found it that way and would implement there, because you know the crisis continues. We are all hoping and praying that it goes away, but till then, information that we have received today should help us a lot. My part was just to reiterate things that we should not panic, and there are agents that are safe to be used even in these current situations. So it was indeed a pleasure to be here with all of you, and particularly with my good friend and colleague Wasim, and we hope that we will continue our interactions with you in the future. So thank you, Gex, for arranging this, and thank you for everyone for being with us.
I'm launching the feedback poll for everyone, so I would request all the attendees to fill up the feedback poll at the end of the session.
Okay.
Thank you.
Thank you.
Sir, just wait. We'll just we're just collecting the feedback.
Okay.
I would request all attendees to please give us the feedback. Also, when you end the session, a feedback page will pop up on your screen, so please fill that one out too. Okay, so I think we are almost done with the feedback. It'll just take a few more minutes, a few more seconds actually. I'm really thankful to Dr. Hamid and Dr. Wasim for being here with us today. So I'm stopping the feedback poll now.
Hello.
Yes. Can you introduce yourself? If you have any questions, please ask. Okay, I'm ending the poll. I am really thankful to all of the participants for being here with us, and I'm really thankful for the speakers and panelists for being here with us. Thanks again, Dr. Wasim. And I think we'll be ending the session now.
Okay.
Thank you.
Thank you. Goodbye.